Thank you for the kind introduction. Dear colleagues, this study found that lateral lumbar interbody fusion at L4-5 has a low rate of neurological, psoas-related and abdominal complications in appropriately selected patients. Nothing to declare. So lateral lumbar interbody fusion is a well-established minimally invasive technique to treat spinal deformity and degenerative conditions. However, early studies suggested that patients undergoing LLIF, that fusion of the L4-5 level was associated with a high risk of neurological complications due to retraction of the lumbar plexus. Therefore, this study aimed to assess the rate of neurological, psoas-related and abdominal complications associated with L4-5 LLIF using a standardized preoperative assessment and procedural technique. This study included 517 patients who underwent this procedure, recruited over a 5-year period from 3 different countries. Patient demographic details, the details of the surgery itself, complications, and reoperation at 30 days, 90 days, and 1 year were analyzed. The average age of the population was 65 years, with an even enrollment of female and male patients. About 13% were diabetic and 5.5% were active smokers. The mean operative time was 107 minutes, estimated blood loss was around 140 milliliters, and the length of the stay in the hospital was about 2 days. Vascular anatomy was carefully assessed preoperatively. Centralized vessels, as you all can see on the figure on the left, are safe for transpsoas access, whereas lateralized vessels, as shown on the figure on the middle and right, are unsafe, as these can obstruct the lateral approach to the L4-5 disc, making them a contraindication for the procedure. Furthermore, careful assessment of the psoas anatomy is required due to the risk of lumbosacral plexus injury. An anteriorly located psoas identified as Mickey Mouse ears is a relative contraindication for LLIF. Then iliac crest height relative to the L4-5 disc space was assessed as well. A high crest projecting above the midpoint of the L4 vertebral body poses technical challenges and was deemed a contraindication. The site chosen for the transpsoas approach also depends on the coronal obliquity of the L4-5 disc. In patients with coronal obliquity, as shown on the figure on the right, approaching the disc on the concavity may be preferred, particularly when multi-level LLIF is planned to reduce the exposure which is required. For the surgical technique, a standardized lateral retroperitoneal approach using a transpsoas split was utilized. Triggered EMG dilators were placed at the junction of the middle and posterior third of the disc and stimulated. Low thresholds prompted redocking of the dilator. Now moving on to the complications we've seen in our study. 14 patients experienced at least one intraoperative complication. However, it is important to say that none of these complications were LLIF-related. 125 patients had at least one postoperative complication. 2.6% of these complications had persistent neurological complications. Roughly half of them were psoas-related. In terms of the psoas-related complications, 0.6% of patients had persistent thigh pain and 0.6% had persistent hip flexure weakness. And here again, not all of those were LLIF-related. For the neurological complications, none of the persistent complications were related to the procedure, meaning the LLIF. Within 90 days, 37 patients required a second surgery, primarily due to instrumentation-related issues. Within 1 year, 4 more patients required a second surgery, again, mainly due to instrumentation-related issues. Subgroup analysis did not demonstrate an increased risk of pseudarthrosis in smokers. So, in conclusion, L4 LLIF has a low rate of neurological, psoas-related, and abdominal complications. It is a safe procedure in patients with appropriate indications following a standardized preoperative assessment and surgical technique. Thank you.
So thank you. Some questions from direct questions on the mic. A question from the app. So, how did you manage this vascular complication?
Sorry?
How did you manage the vascular complication?
The complications?
Vascular.
So the postoperative thigh pain was just monitored, and most of these complications resolved within the first year. And unfortunately, the rest of the patients who had persistent thigh pain are still taking medications, but this is really just a small percentage.
And what kind of cage do you use? PEEK or titanium?
That's a titanium implant from Invasive.
Okay.
Yeah.
One question
printed.
from my side. What is your length of stay? And do you want to perform ambulatory surgery or decrease your length of stay?
I'm sorry, I missed the first part of the question.
What is your length of stay?
The length of stay in hospital?
Yeah.
About 2 days.
2 days.
And how did you, I missed that maybe, how did you find that out whether it was related to your LLIF or not? Because if the...
So, in terms for the neurological complications, it was related to the LLIF if the neurological deficit matched the L4-5, so the height of the neurological compression, and also if there was not any other kind of causal lesion, meaning instrumentation-related issue like malpositioned screws or persistent neurological compression.
So then it was not related to the surgery at all? It came later because the
Yeah,
patient doesn't mind whether it's LLIF if he after surgery has a deficit.
That came later. Or also if the problem was on the other side. So if you have been doing the LLIF from the right side, then there were problems on the left side, for example.